Welcome everyone to another class of Muthuswamy Virtual University of Postgraduate Ophthalmology. So I am Dr. Koushik Tripathy. I am practicing at ASJ Hospital, Kolkata. So I am a faculty member at MVUPGO. So I sincerely thank Professor Muthuswamy Palaniaswamy sir, Dr. Vijay ma'am, Dr. Khada ma'am, the other faculty members and the members of the MVUPGO. So this will be a mock exam. We will allow around 4 to 5 minutes for each candidate. If you are not speaking, please do not prompt, and you have to mute. So when you are answering, if possible, please turn on your video camera, because the approach or your body expressions, they also matter. Introduce yourself first. So this is just a mock exam. We are all learning. I am not the examiner. I also learn. I do this thing to actually read myself only. So basically, examiners are there to help you. They want you to pass. So if just relaxed, understand what the question is, and then answer. If you do not know, you say that I do not know. So try to and keep it simple, and try to think about the most common things. So examiner wants to know what you will do, and not what can be done or what is written in the book. Do not go to theoretical discussion first. Answer the practical aspects first. So you must not miss vision or life-threatening diseases, or iatrogenically cause someone to become blind, or someone to die, or miss something which is life-threatening. So examiners must be convinced that patients are safe in your hand. So please do not say that I'll refer to retina consultant, I'll refer to oculoplasty consultant. They do not like that. You have to know what the other subspecialty consultant will do. And you can say that I'll collaborate with the specialist for the surgery, but you also need to know the surgical steps if the surgical steps are asked. So you have to practice history taking, evaluation, management of all patients in all specialty in your OPD. And it is better that if you understand your weaknesses, and you examine those patients in your OPD, and then get the findings verified by a colleague who has been fellowship trained on that specialty. So if you have any question, you can add to the Zoom chat. So in exam, definitely never argue with the examiner. If the examiner says something wrong, also do not argue there, because that will he or she will take this to his ego, and there will be your chances of passing will reduce. So do not say that there are five causes or six causes or seven causes, because once you go on remembering those, you might be stuck at fifth cause, and the sixth cause may never come to your mind. So just try to mention the common causes and go forward. Do not mention that there are only five causes, there are only six causes. It doesn't happen like that. So do not utter unnecessary sentences. When you are examining a patient, you have to show your professionalism, and you have to show your compassion. Do not become angry. Do not hurt patients. Do not the tear from the patient's eye should not come. Try to show compassion, and try to show professional behavior during the exam. And also, obviously, you will have to practice it in your OPD. Do not discuss outside the exam hall, because you get fixated on a diagnosis, and then you examine the patient, and you try to match the finding with the your prefixated diagnosis. You have to, what the examiners want is that your how you derive the diagnosis, or how you plan your management. So if there are medical treatment options available, you tell those first. Do not miss a systemic disease. Do not mention uncommon things first. And sometimes, because there are many stations, one station may go bad. Do not keep on thinking about that. So examiners love humble doctors who are professional, and who are conservative in their approach, who are well prepared, and who are conceptually strong. So who will volunteer for this? This is a
Yes, sir, I can volunteer. No
Yes,
one else.
please introduce yourself.
Good evening, sir. My name is Dr. Aditya Vikram Sharma, and I'm
Yes.
practicing at Rajasthan. Sir, this is a fundus picture showing disc pallor Mid-peripheral RP changes with bony specular pigmentation and generalized arterial attenuation.
Okay. Then what do you think this patient may have?
This looks like a case of pigmentary retinopathy, most likely retinitis pigmentosa.
Okay. You told mid periphery. What do you mean by mid periphery?
Mid-periphery, sir, between the first arcade and the
What?
peripheral vessels.
Peripheral vessels meaning? So you'll read about what how there are two classifications. One is clinical anatomical classification and anatomical classification of the like clinical macula. What is clinical macula? What is anatomical macula? What is clinical phobia? What is anatomical phobia? What is posterior pole? What is mid periphery? And what is periphery? Dr. Aita will read. So
Okay, sir.
if you think that is this patient is retinitis pigmentosa, what specific visual symptoms may the patient have?
Sir, the patient will present us with the complaints of a diminution of night vision
And
and difficulty in seeing in dim light.
and
And
so difficulty in delay in dark adaptation. So they may
Dylan,
tell
oh, okay, sir.
that yes, I'm going. I go to a uh, movie. I have difficulty in understanding the seat, or I by mistake sat near another person. So like
Okay,
something
sir.
like that.
Patient can have the loss of peripheral side vision also, some patients.
Okay. Yes. And what is the triad of this disease?
So disc pallor, bony spicule pigmentation, and atrial attenuation.
Okay. So what are the systemic diseases you that may be associated with this kind of feature, Dr. Aditya?
Sir, the systemic disease in case of RP can be deafness, which is seen in Usher syndrome and Refsum syndrome.
Mm.
There can be the presence of acanthocytosis in case of Basson-Conwicks syndrome, or the patient might be having ichthyosis also, or if a patient is having extraocular
Ichthyosis is seen in which condition?
Refsum syndrome, sir.
Okay.
And if the patient is having difficulty of eye movements, bilateral symmetrical doses, it can have Cairns-Sayre syndrome also, and the patient is having for polydactyly and hypogonadism. It can be a case of a Bartle-Biedl syndrome.
Excellent. Okay, Aditya, you did very good. I think 5 minutes are over. So
Thank
we'll
you,
go
doctor.
to the next candidate. Who will volunteer now? Anyone? This is just a mock exam. I am not the examiner. So please volunteer. So this is the other A. So anyone?
Okay, sir, I'll
Uh,
volunteer, Dr.
so
Malati.
Dr. Malati,
Okay.
please introduce yourself and discuss this photo.
This is the fundus picture of right eye showing a normal disc and normal CD ratio. Vessels appear normal.
So
Uh,
I'll request to not mention CD ratio. Tell cop to disc ratio. Do not
okay.
mention short forms. Yes.
Okay, the cup disc ratio appears to be 0.3. Then in the macula, there appears to be pigmentary changes along with multiple flecks.
So what do you think the patient has?
So it is suggestive of a macular dystrophy, probably Stargardt's disease.
Okay. So what do you if it is Stargardt disease, what do you think the OCT picture would be? Optical coherence tomography.
There could be a fluid accumulation in along the sub-RP layers with the materials deposited, lipofuscin deposits corresponding to the flex seen in the fundus picture.
No, is there fluid? So usually in Stargardt disease, you will not find any fluid. So do not mention anything which can go wrong. So there may be fluid if there is a choroidal neovascular membrane.
Okay,
So
okay,
this
sir.
is wrong. Do not mention
Mm.
anything which is wrong. Because there is macular involvement, subretinal flex may show some subretinal deposits. That is okay. But do not say fluid, because fluid means some collection. There might be some tissue defects also, which are called optical gaps or foveal cavitations, which might be seen in cone dystrophy. But typical fluid or intraretinal or subretinal fluids are not seen in
Okay,
this kind of disease.
okay.
So how do you manage this such a patient? Like if you see this eye, how do you proceed with the management?
There's no absolute cure for this condition, but we can use low vision aids. First, we can start with depending on the severity of the disease, we can do a refraction and give appropriate glasses and a periodic follow-up. Following that, if there is a deterioration of vision, then we can give low vision aids.
Okay. Anything else?
I'm not
So,
sure. Mm.
my suggestion would be, do not mention that there is no cure for this disease.
Okay,
You can obviously help the patient by refraction glasses and low vision aids, and it will depend on the vision. When they discuss like how do you manage the patient or how do you investigate the patient, you go from the history. Like I will want to know what is the problem from with which this patient has come to my OPD. So such cases, if there is no macular atrophy, they might have very good vision also, and
okay.
so that then they might not need low vision aid also. And then you say that I'll like to see the other eye. This is very important. The examiner
Uh,
want to see this, because if there is this is an inherited retinal disease, other eye should show similar kind of thing.
okay,
And
sir.
then before managing, go at least minimum investigations for at least a fundus photo and OCT, and then I'll see, and also I'll get the vision is important, and what practical difficulties they have. You have to know that, otherwise you will not be able to manage. And in hereditary dystrophy, you definitely tell that I'll like to see the
Other
uh,
eye.
other eye, and also the family members of the patient. So that is
Okay, sir.
another thing which is important. And which drug should is expected you are expected to avoid in such a case?
Vitamin A,
Why?
vit- because it is um, toxic to the. I'm not sure, sir. I forgot this.
Okay. You,
Mm.
you will read what is the relation of this deposit and vitamin A.
Okay, sir.
Okay. What is the gene involved in this such a situation?
ABCA4 gene.
Okay. How is it transmitted?
It is autosomal recessive, sir, mostly.
Hmm. Okay, what are the other features of ABCA4? What are the other phenotypic manifestations of ABCA4? Can ABCA4 only result in this kind of disease, or can it result in something else also? So this you'll have to read ABCA4. What are the phenotypic heterogeneity of ABCA4?
Okay,
This is
sir.
important also. Yes, excellently done, Dr. Maluti. Who will volunteer next? So this
Thanks.
is the other eye of the same patient. What we can take someone in this also. Anyone? Please volunteer. Dr. Gulsanga. Dr. Gulsanga, are you
Yes,
there?
sir.
So
Yes, sir.
please describe this picture, and
Okay.
uh, please describe first.
Okay. This is a colored fundus photograph of the left eye showing a clear vitreous, a healthy looking disc. Vessels are originating from the center. They have normal vasculature. In the macular area, there is a greenish sheen. with a dull reflex, and surrounding yellowish pisciform flecks can be seen.
So what is your preliminary diagnosis from this?
My differential diagnosis would include macular dystrophies like fundus flying maculatus. It could be cystoid macular edema or epiretinal membrane.
Okay. Why is cystoid macular edema a DD here?
Um,
What would you find in cystoid macular edema?
Sir, generally, I wouldn't find these flecks in cystoid macular edema, but I kept it as a differential because that would present with a dull reflex.
No, that would present as dull reflex, but it is better not to in
Okay.
cystoid to tell it as cystoid macular edema. There should be what is the fundus finding of cystoid macular edema? It is not dull reflex. What is the exact finding?
Flower petal appearance.
Yes, flower petal or
Yeah.
honeycomb kind of appearance should be seen. So you are not seeing.
Okay, sir.
So CME should not be a DD
Okay.
here. So what could be a
Okay.
DD? If there is a greenish subretinal lesion in the posterior
Um,
pole
uh,
in a 80-year-old
um,
male, what would
Choroidal
be?
neovascularization, sir.
Yes,
It
that
could
could be a
be
DD.
wet
Yeah.
AMD.
That could be a DD, but do not tell CME. So
Okay, sir.
how do you know which system is involved from the fundus finding? How do you know whether cones
Mhm.
are involved or the rods are involved from the fundus finding?
When cone involvement is predominant, then macular findings are more prominent, whereas in rod involvement, retinal RPE hyperplasia or mid-peripheral involvement is more common.
Okay, and what are the other features of other fundus findings of cone dystrophy? You said macula will be involved. What other
Yes, sir.
features will be? What other clinical features may be there in macular involvement?
So there could be bullseye maculopathy. There
Yes.
could be vitelliform looking lesions, which may also
No, no,
vitelliform lesions may.
it is okay. It is okay. Fundus finding we are done. What are the other
Okay.
clinical features, history-wise or other things which can suggest that
Um,
this person might have a cone system involvement?
okay.
And
So
how
on
do you
history,
confirm that?
generally these patients, on history, generally these patients have childhood presentations of decreased vision. They have difficulty in bright light, hemeralopia. They have decreased color vision, and generally they have a family history. And then on examination, their color vision is decreased, color contrast is decreased, um, and apart from that, on investigation, their ERG and EOG, both of them have generally subnormal findings.
So
And
here you are making a mistake. Why would EOG
okay,
be abnormal here? So do not go do not tell generalized statements. So EOG
okay,
may or may not be abnormal. So do
okay,
not
sir.
it is they have told you just cone problem. So EOG may be abnormal if there is RP involved also. So better not go there. You say that cone system. What are the tests? What are the specific EOG tests, ERG tests on which you see cone? Which
So
specific
a
tests?
full field ERG, the cone and cone flicker will indicate cone
Yes.
involvement.
Okay, so there is this ICACB criteria on which they have divided like 5 specific protocols which need to be done. You will write on the group about this specific
Okay,
protocols which have been systematically mentioned in their guidelines. So you did very
okay,
good,
sir.
Dr. Kulsanga. Thank you.
Thank you, sir.
Thank you.
Thank you.
So who will take next? So please, I'll request other people, please write their full name so that we can request them. Dr. Shreyas.
Yes, sir.
Who is this?
Sir, I'm Dr. Serish. Dr.
Dr.
Serish
Sherish.
Khan.
Okay, Dr. Sherish. So this is a OCT of a patient. So please describe this OCT and please describe this OCT.
So, okay. Sir, this OCT is showing foveal thinning and um
Outer retinal thinning or inner retinal thinning?
sir, outer retinal thinning.
So in which cases do you see outer retinal thinning?
Sir, in cases of this inherited retinal dystrophy such as RP in
And
Stargardt's
uh,
and
okay. You told RP. So
yes, sir.
In RP,
But in
where would you?
RP, sir, it okay.
No,
In
you
RP,
you have told RP, that you justify why would RP cause a
in the
foveal
end
thinning.
stages, in the end
Yes,
stages,
yes. So,
especially,
so
but
do not go there. Do not.
yes,
So we have to be. We are physicians. We have to say common things first. So
yes,
RP will not cause macular atrophy at the onset. No.
yes,
So
yeah,
what
at
will
the
cause
end
the
stage,
what will
cone,
cause the macular? Yes.
cone
Cone
dystrophies.
dystrophy. Yes. So you see the image. You is the like outer atrophy everywhere, or there is there some outer retina present somewhere in this image?
Sir, it is present in the extrafoveal area.
Yes, so that means there is just foveal involvement or macular involvement, but outside the fovea there is this certain like ISOS junction or external limiting membrane are there. So that means it is a central problem. So that means the cone system is mostly involved. So do not tell RP. If you do not jump to that.
Okay,
Okay.
okay,
So what
okay,
are the
sir.
other diseases which can cause outer retinal atrophy like this?
So the cone rod dystrophies, the
Yes.
Stargardt's disease,
Yes.
and
What is difference between cone rod dystrophy and rod cone dystrophy?
sir, in cone rod dystrophy, the macula is involved first.
No,
So
no,
there
no,
are
no,
the
no, no, no. What is the difference in nomenclature of that? Cone rod and rod cone.
cone rod and rod cone. The rod cones include the retinitis pigmentosa
No, no, no.
and
Why is like what is the conceptual difference of cone rod and rod cone? That is what I am asking.
sir, in the rod cone, the peripheral retina is involved. The rods are involved first, and
Yes,
in the cone rod, the cones are involved. The central retina is involved first.
yes. So you told
So
that cone dystrophy, Stargardt disease, etc., or progressive cone dystrophy. That is one thing. What other things can cause this kind of outer retinal atrophy? What common
Mhm.
cause diseases can cause this kind of thing?
sir, anything that will cause a geographical atrophy,
Like
like mm, sir, end stage of CNV.
yes, in stage of AMD and
Yes.
and
And sir, even in end stage of Best disease,
yes and
and mm,
if a young person has this kind of thing, foveal thinning in one eye, and
Stargardt
yeah,
in one eye. Okay. Uh,
and other eye is normal, he received some laser or something in that eye.
CSCR.
Yes, CSC.
Chron-
Yes, so
yes.
this kind of you have to mention the common causes first. So AMD and CSCR can also cause. If there was inner retinal thinning, what causes would you think of?
In case of inner retinal thinning.
Uh,
Mhm.
So you will
Mm,
read that. You will read that. We are
okay.
already past time. You will read what are the
Okay.
causes of outer retinal thinning, what are the causes of inner retinal thinning, what is the current guidelines, current nomenclature of outer retinal thinning or atrophy in AMD. You will read and you will just post a chart A on that.
Okay, sir. Thank you, sir.
Yes. So, but you really you answered very well. Thank you. So do not
Thank you.
tell RP. I'll request do not tell RP in macular kind of changes because it will it will be bad. So who
Okay,
will
sir.
volunteer next?
Sir, I will. Shagil Khan.
Dr. Shagil, please introduce yourself.
Sir, I am Dr. Shagil Khan working with Dr. Agarwal Sai Hospital.
Okay, Dr. Shagil. So please describe this image.
Uh, this is okay. On the left side, there is a fundus photograph of the right eye on the
Now, is this a fundus photograph or is this something else?
right free.
So is it red free? So this is very important. I'll request all of you to please at least understand how red free looks like, how infrared uh, image looks like, how autofluorescence looks like. It is important, and if you say opposite, that will be a negative marking. So what
Okay,
is it?
sir. Most likely fundus autofluorescence.
So just now tell is it fundus autofluorescence or red free or fundus photo? What do you think?
Sir, fundus autofluorescence.
Okay, fundus autofluorescence. Why is it fundus autofluorescence, not red free?
Because, sir, in the center there is a hypo
Yes,
reflective area,
and
and
how will disk appear in a red-free image?
sir, bright.
Yes, and there is also granularity, some amount of underlying granularity of the fundus, which suggests that this is uh, fundus autofluorescence. So you will read what are the difference between, you will post images of multicolor image, red-free
Okay, sir.
image, uh, fundus autofluorescence, infrared.
Okay,
And
sir.
what do you see in the right side?
Right side shows the OCT.
Hmm.
There is a splitting of the inner retinal layer in a bicycle spoke weak-like pattern.
No, this is
And
not bicycle. What is bicycle spoke like pattern? Is it seen here? So do not mention anything which is controversial. Bicycle spoke is a fundus finding. When you see those patients in the fundus or you are doing
okay,
them by microscopy, then because there are cysts or though this is all something else, as there are cysts, they will appear. The cysts will there will be a honeycomb kind of appearance, but the intervening septa between the cysts may look like they are radiating
okay, sir.
from this. So that is giving that will give spoke wheel pattern. Not this OCT is not showing spoke wheel pattern.
Okay, sir. So
Okay.
there are septa in the inner retinal layer,
Hmm.
and I would like to check the vision of the patient and the other eye of the patient. Look to the periphery for
No,
any
no.
association.
What is your diagnosis from this? What is your diagnosis
It's
from?
my differential diagnosis is juvenile X-linked retinoschisis. It could
Okay.
be it could be cystoid macular DD would be cystoid macular edema,
Yes.
tractional maculopathy, diabetic macular edema.
No. Why would tractional maculopathy come in the DD?
Because the traction can also cause
No. Is
this.
there a traction here?
No, sir.
So do not mention. The DD is phobiocysis or juvenile retinoschisis, and CME due to various causes including BRBO, CRBO, diabetic macular edema, etc.
Okay, sir.
So if you think that it is X-linked retinoschisis, what would the person be, male or female, and what would the age be?
Patient would be a male patient, adolescent male, and the onset of age of onset is around 5 to 10 years.
Okay. So what would be peripheral findings of this?
Periphery, there can be a peripheral retinoschisis.
In how many percentage of cases?
Sir, I'm not
How-
sure, but
Hmm.
it's around 10 to 20%, I think.
No, wrong. You will read. And how many percentage of cases have this kind of central problem?
75 to 90% around.
Yes, most of the cases will have central problem. And what is
Yes,
the this thing? What is the inheritance pattern of this disease?
sir, it's X-linked
Explain what?
recessive.
Okay. So that means it is who transmits the disease? Male, mother or
The
father?
females are the either the affected male or the female carriers.
What other X-linked diseases do you know of? Which involve eye?
Sir, choroideremia, gyrate atrophy.
Gyroid atrophy, uh, X-linked recessive. So you will have to read very carefully. You do not mention anything which is wrong, please.
Okay, sir.
It is not a, though examiner will try to poke you and they would want a rapid answer from you, but it is your target to not be like fast. You just think before you speak. So
Okay,
now
sir.
you tell what is the gene involved in gyroid atrophy. You do not
Sir,
know. Do
I'm
not
not sure.
so do not mention no. So please, like if you tell something, the examiner can go that way also. So your A would be homework would be to to make a list of the diseases: X-linked recessive, X-linked dominant, autosomal recessive, and sporadic diseases in ophthalmology. आप एक
Okay,
लिस्ट
sir.
बनाएंगे, आप ग्रुप में डालेंगे एंड ट्राई टू आप प्रिंट करके घर में मतलब यू कैन पुट इट ऑन योर होम सो दैट यू रीड इट एवरी डे. तो गाइडेड एट्रोफी यूजुअली इज नॉट एक्स लिंक्ड रिसेसिव. ठीक है.
Okay, sir.
But you answered very nicely. So and also read about the other features of X linked retinoschisis.
Okay, sir. Thank you,
Okay.
sir.
Okay. So thank you. We'll get go to the next candidate. Anyone please volunteer. So this is a mock exam. I am not an examiner. So just Dr. Gauri.
Yes.
Please discuss this image.
Yes, sir. Yes. So the above picture shows uh, the picture at the top shows OCT macula of the right eye. There is a vitreomacular adhesion at the vitreomacular adhesion at the interface. The inner retinal layers appear to be normal. The outer layers, the inner and the outer layers appear to be separated with a hyperreflective material, which is over the RPE in the subfoveal area.
So, what do you think is happening, or what is the DD here? How would you manage such a patient if this thing is given? What is your DD, Dr. Gauri?
So my differential diagnosis would include yes, sir.
Uh,
1 second. Huh. So you can hear me now? Am I audible? Yes,
yes,
sir.
yes,
So my differential diagnosis would include Best disease.
yes,
Then it would be CNVM,
yes.
and it could be, sir, if I would if I would ask for history of trauma, there
Hmm.
can sometimes be subfoveal bleed also, subfoveal
Yes.
hemorrhage.
Excellent, excellent. So this is the regular DD. So why? What is the difference between vitreomacular adhesion and vitreomacular traction? You told vitreomacular adhesion. Why is it not vitreomacular traction?
Sir, the sir, 1 second.
Why is it not VMT? Why is
So,
it VMM?
so because there is normal foveal contour, the foveal contour is not altered. There is no pull on the inner retinal layers on the ILM.
Basically, the inner foveal architecture is not altered by the pull of the
Yes, sir. By
macular
of the
contact.
vitreous.
So, how would you confirm the diagnosis?
So, sir,
And if I say that this patient is around 50 and
around 50.
both eye has similar kind of appearance, so what would the diagnosis be? Well, differentials be?
uh, Around 50 years old. So still,
Yeah.
sir, then my differential would first go to wet ARMD.
Yes.
Then it would be adult onset vitaliform disorder. Although it is in most of the cases it is not bilateral, and then subretinal hemorrhage.
Yes. Excellent. So, how would you know how would you know differentiate from a vital from lesion from a CNVM?
So, sir, there are three investigations that we can do. First investigation is fluorescence. Second investigation would
First
be
was what? Your voice got muffled.
the
What was the first one?
fundus autofluorescence, sir.
Okay.
Autofluorescence imaging.
Okay. What
Yes,
would
sir.
it show? What would it
Sir,
show?
autofluorescence would, sir, the lesion in Best disease is a full material, which will be autofluorescent. In Best disease, in CNVM, that lesion will not be autofluorescent because there will be there will be blood vessels actually in that lesion, so that's why that will not be autofluorescent. If
Okay.
there is a scarring, then it can actually if there is a scarring, then that can actually be hypoautofluorescent,
Okay.
and subretinal hemorrhage will also be
Okay.
hypoautofluorescent.
What are the other investigations which you will do?
Then we can do fundus fluorescein angiography, and we can do OCT angiography. In
Hmm.
OCT angiography in CNVM, we will we will be able to see increased flow in the blood vessels of the lesion, which will there will be vascular pattern that would be seen, which would point towards CNVM.
So, if this is a CNBM, what kind of fluorescence would? What are the types of leak in CNBM in angiography?
Sir, there could be
What are the types of
it
CNBM
can be
according
occur.
to
Could be
angiography?
according to
What do you think this kind of, if it was a CNBM, if it was a CNBM, what would be the angiographic appearance of that?
so
What would be, would it be
so
occurred
type
or
this would be
occurred or flaccid?
so this would be type 2. So this would be type 2. Uh,
Meaning
uh,
color classic.
Sir, lacy pattern, classic. It's a
Yes.
classic.
So you will just you answered very nicely. Gauri, you are practicing retina, no?
Yes, sir.
Yes. So very nicely answered. So but just make a list of like type 1 and type 2. What is the
Yes, sir.
OCT appearance and what is the angiographic appearance? So occult cinemeum, what are the types of occult cinemeum?
Sir, occult CNVM could be, sir, it could be wrap, sir, it could
No,
be,
no, 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 no. What are the appearance? What are the types of appearances of occult cinemeum in
sir,
angiography?
so late leakage of unknown source,
And
or and sir, the second one I cannot recall, sir.
so yes, so this is important that the examiners will ask for the keywords. So you need to
Yes, sir.
answer the keywords. So you will have to read this and
Yes, sir.
also post one image of each of the occult
Yes, sir.
syndrome. But you answered very nicely, excellent. And what
Okay.
is important that she answered the common answers first. So that is what we is needed. So this we thought of as a adult onset vital from macular dystrophy, but you have to answer the common causes first. So can anyone
Definitely, sir.
take this? Thank you. So can anyone take
Thank
this angiography? Like, sorry, the image? Anyone who have not answered? So this is just a mock exam. As I am saying, we are just trying to learn and we are trying to find out the areas where we can actually read and improve more. Anyone, Dr. Barsha?
Sir.
Please discuss the image, this image.
So this is the fundus fluorescent angiogram of the right eye showing hyperfluorescent disc margins along with
What phase do you think is this?
sorry, sir.
Which phase? Arterial phase, arteriovenous phase, venous phase, late phase?
It looks like arteriovenous phase of the fundus fluorescent angiogram.
Why? What are the features of arteriovenous phase?
There are feeling in both arteries and the veins.
So why is it not venous? So if there is feeling of both areas, so why is it not venous? So
It can,
you will read the differences of how do I identify prearterial, arterial, arteriovenous, and venous phase from seeing the image itself.
yes, sir.
Okay, you will read and you will prepare a like table and post. Yes, and what is the finding here?
And there is hyperfluorescent spot over the over the fovea.
Okay, how do you know that whether it is a leak or staining, leak or window defect? How do you know?
So window defect occurs early in this stage of FFA, whereas leakage when the leakage occurs over the later phases of the FFA, there will
Yes.
be progressive increase in the hyperfluorescence as the dye passes.
Increase
To the
in hyperfluorescence means what characteristic of hyperfluorescence will increase?
intensity.
And size. Intensity and size both will increase if there is a leak.
Yes, sir.
Yes. So if there is and for that you need to see the earlier image also, because otherwise how would you know whether it is increasing or not? So I say that this is increasing. Then what would be the DD? If the hyperfluorescence has increased in intensity and also size.
So the first would be central serous chorioretinopathy.
What is the appearance? This the what would be the leak, a pattern of leak in CSCL?
So there could be ink blot pattern or smokestack pattern of leak
But
on.
this has a round kind of thing, no? This
Yes, sir.
can you see my cursor?
Yes, sir.
So this is a kind of round kind of thing. So in CSCR there will be a point which will leak. If it is point which is increasing in size, it is ink blot. If it is a point which the fluorescence is the hyperfluorescent area is going upwards and then forming a mushroom like or a umbrella like thing, then it is a smokestack. But here
Yes,
there is a not a single point, it is an area of hyperfluorescence, no?
yes, sir.
So
It,
if the patient is around 50 or 55, and this kind of appearance, and the hyperfluorescence increasing, what would be the DD here? First DD.
It could be um, it
55
could be
here, no. It is
yes,
macula,
sir.
it is in the macula, and there
Yes,
is a
sir.
macular problem, and it is a old age patient. So what could be the cause of leak in the macula?
There could be wet AMD, sir.
Yes. So another thing, look, this the timer is showing 3:47. What does it mean?
It means it is the time. It's the time
So
at
time is 3:47. Then what is the usual time of arterial, prearterial, and arteriovenous and venous phase? You will read. So there are multiple clues to the question. So you have to examine many things and say. So if it is CNVM, how would you treat?
it depends upon the location of CNVM. If it
Yes,
is
this kind of CNVM, this person, how would you treat?
so it could be treated with photodynamic therapy uh, with
Look,
vertiporfin.
for dynamic therapy, most of the people do not use. So we have to go. What do you practice, Dr. Barsha?
So I practice retina, sir.
Okay, no, why do you practice?
I'm not working currently, so I'm from Nepal, but I'm not working
Okay,
currently.
but look, PDT can be done, but it is not the first choice, no.
Yes,
For
sir.
CNVM, which is involving the phobia, would you go for PDT or would you use something else?
So we can use intravitreal injections like
Yes. So tell that first. Intravitreal injections, and what are the protocols you know of intravitreal injections
so in CNVM, sir.
in CNVM? Yes.
I cannot recall that, sir, at the moment.
Okay, you'll have to read like what are the specific protocols by which anti-VEGF agents can be given, and also just prepare a chart of the anti-VEGF agents and their specific characteristics.
Yes,
Dr.
sir.
Patsa, you answered very well. So, but we need to go to the like common things should be mentioned first. That is
Yes,
very
sir.
important. Yes. And also, when you are trying answer, you ask the patient, sir, what is the age of the patient? Age will give you a very good clue about what the clinical scenario is. Thank you. Who will take the next?
Thank you, sir.
Yes, thank you. This is the image. Who will take this? Dr. Meena, Dr. Manna, Dr. Manna James.
Yes, sir.
Yes. Please introduce yourself and please describe this image.
I'm Dr. Munna. I'm from Kerala. This is the fundus fluorescent angiography late phase showing hyperfluorescent lesion in the macular area. And it is suggesting of uh, can I know the age of the patient, sir?
Age is 25. Both are similar kind of thing.
Then it is more suggestive of some macular dystrophy like Best disease.
Okay, why based disease? Why based disease? What will be the fundus fluorescein angiogram finding of a based disease patient?
Fundus fluorescent. Uh,
So if this is based disease, there is something in the macula, there is something outside the macula also, no? Paramacular region, there is something. Around the macula, there are some dots, white areas. What are these things?
um,
So if,
are the flex.
okay, if there are plaques, then what would be the diagnosis here? If there is both has similar things.
There will be Starbucks repeat.
Stargardt disease. So in the phobia, why is it so white? Why is the phobia so appearing so white, so bright?
Due to leakage, maybe because of
We told about the leakage. No, in leakage, what is the margin? Like, look, this margin is
it
this.
will be
Can,
increasing
can,
in size and intensity.
no, no, no. The if you say because we do not have the other images, so but the image, the white part, the maximum white part in the phobia, what is the margin?
Yes. It is localized to the macular areas.
No, no,
foveal area.
but can you see my cursor? The margin is very well
Yes, yes,
defined. No,
yes. Well
this
defined.
area, the
No,
margin is well
yes,
defined. So in leakage, is the margin well defined or ill defined?
indefined, sir.
So if it is not leakage, then what could this be? What are the other causes of hyperfluorescence?
Height should
Leakage.
be exceeding.
What are the other causes of hyperfluorescence? Leakage is one, and what are the other causes? So you will rate the look. Most of the time, the examiner will focus on the basic things. So you will read what your would be homework would be what are the patterns of hyperfluorescence, what are the causes of hyperfluorescence, and what are the causes of hypofluorescence. The basic patterns like basic causes of hyperfluorescence and hypofluorescence. So this is a window defect because of the phobia. There is foveal atrophy or macular atrophy, and there is subretinal flex outside that. So this foveal atrophy is causing a kind of window defect. And what is happening to the choroid? Can you see the choroidal vessels here?
Yeah, yeah. Correlative efforts are
No, what is that called? Why is this choroid is not very much visible here? Choroidal vessels.
black coral, projective finding.
What if you are saying that this is Stargardt disease and choroid is not like angiography, choroidal vessels are not very much prominent. So what could this
Black
finding be called?
coral, black
What?
coral.
Dark choroid. Yes. So your questions, you just please read about the angiography. So this is important, and
Yes,
angiography of this Stargardt disease, etc., could be given also. Thank you.
Sir,
Yes.
one doubt, sir. Sir, this dark choroid and the masking thing that is usually seen in fluorescent autofluorescence, or is it seen
No, no, no,
also?
no, no, no. Dark choroid is a finding of angiography, fluorescein angiography.
Okay. Okay,
Mhm.
sir. Thank you, sir.
So back on my body. ঠিক আছে. So this was the fundus photo of this patient and angiogram on the other eye. So who will take this?
I would like to volunteer, sir.
Dr. Aparna, please introduce yourself.
I'm Dr. Aparna Dwivedi. I am from Bhubaneswar. I work at Dr. Agarwal's Eye Hospital and I'm an oculoplasty surgeon. So this is shall I describe, sir?
Yes, please describe.
Yeah. So this is a hazy fundus photograph of the left eye, showing
Which eye this is?
of the right eye,
So
showing.
please, Dr. Aparna, I'll request to be a little slow. Do not tell anything which is wrong. So because wrong, if you do not answer, that is okay, but wrong answers will create a negative impression upon the patient. So how do you know which eye is it?
So the
Right eye or
macula
left
should
eye?
be towards the temporal side.
Yes. So this is right eye.
Yeah.
Okay, they continue.
Yeah, and so arterioles and the venules are the arteriovenules are appearing a bit attenuated, and
Which is more attenuated?
the
Arterial vein.
arterioles are appearing more attenuated,
Okay.
and there is some amount of temporal pallor,
Hmm.
and there are some uh, there are some uh, uh, black color uh, uh, pigments in the mid peripheral area.
Okay. So
So
if you find similar findings in the other eye, patient is around 25 years old, what could your DD be? Very symmetrical, both eyes.
yeah, so my DD will be retinitis pigmentosa.
Yes. Any other thing which can cause similar kind of feature?
Uh, so yes, sir. Late stage diseases of RP diseases can also present with the same findings.
Okay. Do you know what is unilateral retinitis pigmentosa and what are the causes of that?
Uh,
Unilateral pigmented retinopathy.
no, sir.
So
I'm not aware of that.
you read about that. So if this is what would the most likely the inheritance pattern be? What is the usual inheritance pattern of retinitis pigmentosa?
Autosomal dominance is the most common, followed by autosomal recessive, and the least common is X-linked.
So you have to read with reference and post that. And which is most severe?
Sir, autosomal dominant is the most severe one.
No. So this is what you need to understand and you need to remember. Autosomal dominant diseases, at least fundus dystrophies, are more least severe. जैसे West disease. West disease is autosomal dominant, but vision is usually good. Though the fundus may look very bad, but patients have good vision. So autosomal dominant will have the best prognosis, best visual prognosis at least.
Okay.
And which you'll read
X-linked
about.
is the most severe, I
Yes,
guess.
X-linked is the most
Okay.
severe. And what are the like? You will read about the genes also. Can you tell us about one or two genes which can cause retinitis pigmentosa?
So RP65 gene is the most commonly known one.
No, most
And
commonly, but it might not be most common. And any other genes which can cause this kind of retinitis pigmentosa? So, Dr. Apna, you will read about the common genes,
genes, okay.
both autosomal recessive, autosomal dominant, and X-linked retinitis pigmentosa. But you answered very nicely. So, what are the macular problems which can be found in this kind of thing, retinitis pigmentosa?
So macula usually gets affected at the last in very advanced disease, and in late stage we can see till the end. Usually the macula gets spared, so the patient usually has tunnel vision. In late stage,
No,
the
it is tunnel vision, but even though the atrophy doesn't involve macula, can something else involve macula in
yeah
retinal?
yeah because of progressive macular atrophy, MNV can develop. Macular neovascularization can develop.
Yes, and any other disease which can involve macula, even though the atrophy has not involved macula in RP. So you also read about the macular involvement in retinitis pigmentosa.
Okay,
But
sir.
if there is, you find that there are intraretinal spaces in the macula, what would the angiographic feature be, Dr. Aparna, in retinitis pigmentosa?
Macular edema can be there,
Macular edema
in
is there. So
and
you
macular atrophy can be there. So
no,
these,
you saw there is macular edema. OCT also shows macular edema, intraretinal fluid. So if
okay.
you do angiogram, what finding would you see?
So cystoid spaces can be seen.
Can be seen by in angiogram. How do you see through those features?
It will appear hypofluorescence.
So you'll have to read it. How does CME related to RP appear in angiography? What is
Okay.
leaking CME? What is non-leaking CME? What are the causes of non-leaking CME?
Okay, sir.
So
Okay.
thank you.
Thank you, sir.
So this is the other eye. So who will take? I have one, two or three more questions, then we'll close. Who will take next? So this is just a. I am saying again and again, this is just a mock exam. So we are just revising and we are understanding what questions can be asked. Dr.
So
Palni?
I'm
Yes, Dr. Salini. Dr.
yes.
Salini, this
Yes, sir.
describe this fundus or this. What is this test? Describe this test, please.
Sir, this is a printout of the left eye 24-2 threshold visual field analysis. And it seems reliable. And
How do you know this is reliable?
I mean, sorry, I was just looking at the false positive, false negative is off. So, yeah. And the fixation
Okay.
losses, I was looking at those.
What is the threshold? What is the like? When do you think that this is unreliable? When do you
Uh,
think that and this visual field is unreliable? What are the
so,
criteria?
positive and false negative errors more than 20%.
Okay. And how does the machine check for fixation? Dr. Shalini?
So,
How does the
yeah,
machine
so
check for fixation?
I will have to read that
Yes,
up
please read
again, sir.
that. So please tell us what is the finding of this.
Okay, sir. So on the grayscale and the total deviation, since the pattern deviation is uh, not represented. It shows only a central island of vision and peripheral, mid-peripheral tunnel scotoma around it.
Okay, what do you think? What is difference between scotoma and visual field defect? Is there any difference? So you will read about that also. So what do you think this patient has? What could be the cause of this kind of feature?
So this kind of a ring annular mid-peripheral visual field defects, it could be seen in patients with glaucoma. It could also be seen in patients with advanced RP.
If it is glaucoma, do you think it will be central or which side is it usually deviated? The island?
Correct, sir. That will be a temporal island will be
Yes.
spared, sir. So
Okay,
this is
glaucoma.
most likely
Most likely.
macular, advanced RP and rod cone dystrophies
Advanced
with
RP,
predominant rod
glaucoma,
involvement.
glaucoma, advanced RP. What is any other common causes for such narrow visual field?
In patients with high myopia, sir,
Okay,
they could
and
also have peripheral visual field effects.
okay, and any treatment, retinal treatment, which can cause this kind of thing?
Following PRP.
Yes, following PRP also
Yes.
you can see this kind of thing. So your
Right,
question,
sir. Sensitive laser.
your homework would be what are the causes of peripheral visual field defect, what are the causes of centrocecal visual field defect, and what are the
Yes.
causes of nyctalopia. So just tell us what are the causes of nyctalopia.
So the causes of nyctalopia could be this rod or rod cone dystrophies like retinitis pigmentosa,
Yes,
also congenital stationary night blindness.
yes,
And since we are on the topics, then the choroidal dystrophies also predominantly affect the choroid, and the outer retinal rods are predominantly affected. So they also present with early onset nyctalopia.
yes,
Other than that, common causes would be vitamin A deficiency.
and you told another disease, no?
Choroideremia, gyrate atrophy.
Actually, choroidal guided you can tell, but it is better to tell a little later. So any other disease you told something, no? Temporal island of vision, temporal island of vision. What is the cause? Advanced glaucoma. Advanced
Advanced
glaucoma
glaucoma.
patients can also have this kind of thing. Any other diseases? So you will read about all that. We'll post the list about all the causes which can cause
Yes,
night blindness,
nyctalopia.
nyctalopia. And what is treatable cause of night blindness?
So vitamin A deficiency.
And what are the other features of vitamin A deficiency?
Again, I'll have to read up, sir, but they
Yes,
will
take
have
it.
whited spots and conjunctival xerosis, corneal xerosis,
And what is the fundus finding typically called?
pigmentary retinopathy.
Not exactly pigmented retinopathy. You just read about it and what
Yes.
mention what is the specific they have mentioned. So you have answered very nicely. Thank you. So who will take the
Thank you,
next?
sir.
So this was the other eye. This patient had retinitis pigmentosa. So this is a child who is not able to see and he is just doing this kind of thing. His eyes are wandering and his parents are saying he does this kind of thing. He's poking the eyes. So what is this kind of thing? Who will volunteer? Dr. Ayaz or any who
Yeah, I
will
can
volunteer?
volunteer.
Dr. Farzana,
Okay, I
yes.
can. Yes, sir. Sir, this is a picture of a child who is poking his eye, mm, and other things are not visible. So my differential diagnosis, it may be a severe inherited retinal degeneration, like maybe
So what is this called? What is this thing called?
ocular digital ocular digital syndrome.
Digital.
Okay,
Ocular digital syndrome. Yeah.
not syndrome.
Ocular digital. Fine.
Okay. So why is he doing this kind of thing?
Actually, if a patient who doesn't have who has very low vision, but he feels if poking will help him to see better. In during the poking, some phosphines are released, and patients feel like he can see better. So for this, he is
Okay.
constantly poking his eye.
Okay. What is the late side effect of this kind of poking again and again? How will the eye appear?
How you will get enophthalmos? There will be fat atrophy.
Okay. A little better. So which disease can you expect in this kind of patient?
One disease that I might expect liver congenital amaurosis.
Yes. And any other disease which causes severe kind of vision loss? What is the usual refractive error in liver congenital amaurosis?
Usual refractive error is maybe um, mm, uh, high. I'm not sure, sir.
So you'll have to read it. It is
Yes.
very important to understand. Now you'll read about the like common clinical features of liver congenital amaurosis. What are the genetic? What are the common genes which cause this, and what are the clinical features of this?
Okay, sir.
So this is the last, and then we'll close. So this is a patient who has this kind of feature. Anyone who has not answered, please discuss this image. I think everybody has already Xiaomi, who is Xiaomi? So
Sir,
please mention your name. Please, who are you?
I'm Dr. Farhana, sir.
Dr. Parana, please discuss this image.
This is color fundus photography of right eye of a patient showing optic disc the size shape normal and mm, uh, in the blood vessels and the macula is also normal. In the nasal and superinasal side, there is some opacity and which is uh, mm, uh, irregular in shape and um, uh, uh, it may be laser marks.
Okay, so what kind of laser marks are put like this? Which type of laser?
Uh, uh, as I can see the superior retina, and I can
So
see the
they are
nasal and
360.
inferior retina.
It is around 360 degree. So
So
what would be?
if it is a PRP laser,
What is the full form?
pan-retinal photocoagulation.
Okay, so basically, nerve maybe a little temporal pallor maybe there here. So yes, so some people have told that they could not understand whether there was PRP or there well, pan-retinal photocoagulation or it was a patient with RP. So PRP, pan-retinal photocoagulation, because it is laser, it is a man-made thing, and there will be the laser spots will be different than the bony spicule which are seen in retinitis pigmentosa, and also other features of diabetic retinopathy like microaneurysm or new vessels might be, or vitreous hemorrhage might be seen in such an eye, which will not be seen in retinitis pigmentosa. So it is there are some like exam experience where they have told this. So just
Sir,
yeah,
I have one question.
yes.
Sir, in this, how do we know that this is not snowflake deposition in snow, like
What?
in snowflake deposits?
Snowflake degeneration is in the periphery, not in the posterior pole.
It
It
won't.
is near
Okay,
the
sir.
posterior pole. This is near the A. So snowflake is not
Okay,
like
sir.
this. You will read about snowflake degeneration, where, how does it appear, and where it appears, and what is the pathology.
Well,
I will tell.
Okay.
snail slime does not appear like this. The one that we see in early Stargardts.
No. Snail slime. That will be like a shiny reflex in the fovea. That is not in the uh, around the arcade. That is not there. So
Okay.
this is you will say that there are pigmented areas with surrounding depigmentation and which are confluent at some places. Some places they are not confluent, but they are put in a pattern. Like the disc is around one, the nasally it is around 1 disc diameter away from the eye, optic disc margin, nasal disc margin, and the pattern looks like to be hydrogenically formed. And other features of like so typically this pigment pattern is due to laser only.
Okay, sir.
The bony speckles will be like Chinese letter. They will be like thin and oriented in a Chinese pattern. So I'll just spot diagnosis. What is this diagnosis? What is the photo here? Anyone. I'll just finish this because we are already we have passed 1 hour.
Sir, RP, retinitis pigmentosa, sir.
Not retinitis pigmentosa. This is guided atrophy. So
Guided
there
it.
are focal scalloped areas of atrophy because basically this is a case which we reported. So the disease has progressed with time. In 5 years, the disease has progressed. So if somebody please read on the guided atrophy. What is the gene involved? How can we reduce the progression of the disease? What is this? OCT. What does
Cystic
it say?
macular edema, sir.
No, this is not cystoid macular edema.
This is best disease, I think,
Yes,
liposuction.
subretinal deposit in the vitelliform space. The correct A would be vitelliform deposit in the fovea, or below the fovea. So this
Sir,
is feeling.
just OCT above this one, sir.
Yeah, this is foveositis. This is cystoid macular edema, but foveositis, you have to do angiography. Angiography will not show leak in foveositis, but it will show in leak in cystoid macular edema. So this patient had foveositis. Usually, the inherited retinal diseases are associated with foveositis. There are intraretinal fluid field or intraretinal fluids, but angiography will not show any typical petaloid leak, which is seen in cystoid macular edema. So retinitis pigmentosa, guided atrophy, they will be associated with non-leaking CME or foveositis. So this is what is this imaging modality? Can you tell?
Wide field wide field imaging, so wide field fundus photography.
Yes. So someone can this is white field fundus photo, and you have to read about optos. At least how much degree is there, and what is how does it capture the image, and what are the specific light wavelengths that are used. So what is this image?
Hyper autofluence.
This is hyperautofluorescence dystrophy. What is this?
Albinism.
Albinism.
Albinism. Can anyone tell this? This is only seen in the females of the family, this kind of thing. So this is retina consultants, please. So if someone can please capture this image. This is only seen in females. Only the females of the family have this kind of thing, and they also have diabetes. So what is the disease here?
Didmod?
No. So please read and post it in the group. So and this is what could this
This is polydactyly and hypogonadism.
Bardet-Biedl syndrome.
Bardet-Biedl.
And this what is this OCT? What?
Bardet-Biedl.
This is Bardet-Biedl.
Yeah.
And what does this OCT show? The OCT show? What is the disease? What inherited disease can cause this kind of thing?
PMO?
No,
What?
IS-OS junction interrupted, sir.
No, it is not interrupted in the center. No, it is interrupted in the periphery. So what could be the disease? What could be the disease here?
What's the eye? What's
No,
the eye maculopathy?
macula is okay, na? Fovea is okay, but outside fovea there is ISOS junction is lost. No?
Maybe retinitis pigmentosa.
Yes. So in such cases, you have to rule out retinitis pigmentosa. So this is a typical feature of retinitis pigmentosa where the foveal ellipsoid zone, foveal external limiting membrane are preserved, and peripheral things are also there is ERM and other changes. But this is what this kind of OCT can be shown in exam. So what is this? If there
Hemangioma.
what kind of hemangioma?
Capillary hemangioma.
Capillary hemangioma or hemangioblastoma and Hornipel interdisease. So this is another.
It is said in the phobia, sir, and sir, like associated with banded beetle and explained.
Which this image.
Von Hippel.
This is
Von
Hornipel endowed disease.
Von
Not
Hippel.
no, banded beetle syndrome will not be associated with this kind of capillary hemangioma. So another thing, this is, what is this OCT feature called?
Foveal hypoplasia.
Foveal hypoplasia. What is the OCT feature called? This is called fovea plana.
Plana.
Because you will not be, even though you search the search with the OCT raster, you will not be able to find a depression because the fovea has not formed well. So this is called foveal hypoplasia or foveal aplasia, and someone please read about it and post the causes, like which diseases can cause foveal hypoplasia or a. And what is this? I think this is the last image.
Oguchi's disease.
Albinism.
Now, what is the phenomenon called?
Mizo
Mizu Nakamura.
Nakamura.
So which is which is normal photo and which is dark adopted photo?
The right side is the tapetal sheen, and the left is the dark adopted normal photo.
So yes, right side is the
Capital
photo,
sheen, and the
is the photo which is taken normally. If you, the more the light exposure you do, the more white, yellowish or golden it will become.
Yes.
You have to keep it. You have to put patch over the eye and put the patient for at least 2 hours or 3 hours, and then the eye comes to the normal color. So which is shown in A and C. This case we also reported. So thank you. I'll request you all to please read and post your queries and your homeworks there. Thank you.
Thank you so much, sir. Thank you so
Thank
much, sir.
Thank you.
Thank you,
Thank you,
sir.
sir.
Thank you, sir.
Thank you, sir.
Thank
Thank you, Koushik. Thank you.
Thank you. Thank you.
Picture with diabetes, what you just said. Yeah, last one, bro.
Or Dr. Aditya, please post it in the group.
I will.
Okay.
Thank you, sir.